resorption. Internal resorption is also known as pink tooth. The reason why they call it pink tooth, sometimes anterior teeth will actually have a pink color to them. And when you see a pink tooth, you're thinking, huh, it's kind of an odd thing. So then it kind of tells you to take an x-ray of it. So let's see if I can get my machine to behave. There we go. Most times internal resorption, you do not know it is there until you take x-rays. Then you happen to see it. Teeth basically that are involved don't have any pain with it. And when we look at what internal resorption is, it is almost like saying that the tooth gets a cavity on the inside of it and works its way out. So the one that you see here with the ortho, this dark area inside the pulp is where you see the internal resorption. If you think about the pulpal side, the pulp is the center, then you have dentin, and then you have that layer of cementum. Well, it's almost like saying that the pulp is enlarging, and the reason why it enlarges is we're removing dentin. And when the person has this, they don't have any pain with it. Now, the ortho tooth has some other issues that you see going on in that periapical area and up the lateral side of the root. You also see some darkness. We'll talk about that when we talk about decay today. The picture on the right, two teeth are exhibiting internal resorption. One is much larger than the other, but they also have another issue. This is the height of bone, and you can see the PDL is a lot wider there, and the angular bone here, and the bone level is probably somewhere in here. So bone level should be way up here, so they have a lot of bone loss in that area. So that's one additional problem. The other thing, if you look at this internal resorption, look at how thin this is here. They have almost gone through the side of the root. When it goes through the side of the root and it goes through that dentin, then that little layer of cementum, that tooth is basically useless. There's not much else they can do for it. And endodontists typically may be able to get a handle on this. Internal resorption is tough to control to salvage those teeth, but the bigger it is, the worse it is for that person. And when we look at this internal resorption, that's a big one. The distal aspect of the root, this is probably perforated the side of the root. So it's almost like saying if you have a straw and you bore a hole through the straw, that's what's happened. In this case, not much you can do with it, so you take that tooth out. Another good one, and probably has perforated towards the mesial side, and the distal side is pretty much getting close to it. So it just happens. Trauma may do it, but we're not really sure why it really happened. It just unfortunately, sometimes it does. Big one there, a little more irregular. But again, when you look at the tooth clinically, you're not going to see any decay, but something is going internal to it. So that's the advantage of x-rays. So internal resorption, or yes.
So my grandmother actually, this just happened to her this year in January.
Okay.
Like they did an x-ray and it was actually in 2 or 3 teeth. Like it spread. It was super rare, and she's still in the process. They didn't do implants. They're doing a permanent bridge, but they had to like pull 2 or 3 teeth and make a bridge for it.
Yeah. See, and when you get, you should try to get the x-rays of them. It'd be a good one to, we could post it and see what it looks like.
Yeah. He actually sent them. I'm going to pick them up today.
Oh, good, good. Yeah, unfortunately, man, it's a strange little thing, and there's just not much you can do with it, and that's unfortunate. It really is. You know, we do have the advantage bridge work can replace implants, are phenomenal things that can do it, but it's still a pain to have to, you know, deal with it. So, all right, let me type a quick little second here. There we go. I have to, all right, wonderful. Ah, good. I like hearing stories like that because it brings it closer to, hey, reality. People get to see and hear different things, the better it is. But these are examples of pink tooth. The one on the bottom, you can see it's the longer you let it go, the pinkness would expand. And again, it has a very, very minimal hue, and they're only typically seen on anteriors if you're lucky to see it. This one's a nice color. I have a set of, well, not a full set, but I have several extracted teeth that are pink in color, but the person during tooth development, the teeth erupted and they were pink in color because they had a congenital defect with their circulatory system, and it actually bled into the developing tooth structure, so their teeth were pink. Maybe I'll try to take some pictures of them and put them up for show and tell. It's kind of neat to see them. Or if I ever make a run to your school, I'll bring all these strange teeth that I have. External resorption. External resorption is resorbing the outside of the root. So when we look at external resorption, you're probably familiar with this because when we exfoliate or lose baby teeth, the roots shorten up, and next thing you know, the tooth's gone. So that's a normal external resorption. Trauma can externally resorb. Chronic inflammation at the apical area can resorb. Some cyst, and unfortunately some malignancies. Typically with a cyst, when the cyst gets bigger, the cyst is benign, it typically will spread the roots out. But you get aggressive cyst, like an ameloblastoma, when we talk about those later, they will resorb roots. Malignancies, think about you had a little mouse in there and the mouse is chewing away at the root. Well, that's what it does. They resorb the roots that way. I got sent a picture Wednesday from an ex-student from years and years ago. I cover in their office, and I should post it, but I'll probably do it when we get to cyst. I don't know what it is. The kid has a cyst this big in his lower mandible, and it's not resorbing any of the roots. It's gigantic. I mean, it's the size of $50 in your anterior area. So it's interesting. It didn't resorb anything. Primaries. Now, I know we could have a good time and talk about this being letter K and L, and this would therefore be tooth number 19. I know that is fun. You're trying to think, okay, is it the right or the left side? But your letters are always fun. But look at the root or lack thereof. It's been externally resorbed. So the tooth developing underneath puts pressure on the root starts to resorb. As the root shrinks or resorbs, the tooth gets mobile, and that's how we lose baby teeth. So that's a normal process. Trauma, you know, you ask the patient when you take an x-ray, you look at the roots, you can see the central incisors are a little short compared to the laterals. And you also notice that the shape of the end of the root is a little different. So trauma can definitely do it. One of the things that we consider trauma, you could bump it, but orthodontics is actually trauma and can shorten roots. This here is an interesting case. That's a really short root, and this impacted tooth is putting pressure and has caused that tooth to resorb. So what, this is radio opaque, right? What are those? What
Are they fillings?
They're some sort of restorative, yeah. They're an odd shape, and I can't remember the history of this, but it's interesting. This is actually a picture of, it's non-digital. It's when we used to take films, because the A down there that you see. But I think this is what we call a slip-on type of restoration. You'll see some people have like little silver or gold windows or little boxes. That's what I think this is. And if you're not familiar with them, I'll show you some of those as well. Externally resorbed. If you look at this tooth is starting, the root is starting to fade out, but look at how ragged this is. Whatever this is down here, it's aggressive, and it's almost like a little mouse is chewing away. So we tend to think this is more of a malignancy just because of the pattern that you see. And then the last condition, tetracycline staining. Tetracycline, you're going to learn in pharmacology, is a wonderful antibiotic. We tend to use it in dentistry to control periodontal problems. What it's used for in medicine, we can use it for respiratory type conditions, illnesses. There's some variations of tetracycline, like minocycline. It's used for treatment of acne. Well, it's a great antibiotic, but the problem is when you take this antibiotic during tooth development, all right, you incorporate the tetracycline into the hard tissues and you get staining. And it has a very unique stain. We consider it an intrinsic stain, or older term, endogenous staining. Intrinsic is built into the tooth, into the hard tissue. I don't care how much you polish, it ain't changing it. Some of these mild cases, you may be able to get a little variation with bleaching, but the problem is tetracycline tends to stain more dentin than enamel, because if you think about who is closer to the developing pulp, it's the dentin. So the tetracycline's in the circulation, it is brought to the teeth, it stains the dentin. Why we see it as staining is because enamel is actually translucent, so we can see through it. It also stains bone as well. So you're going to learn tetracycline is what we call photosensitive. It's not telling you you're afraid of taking pictures or selfies or whatever. It's telling you that when you take tetracycline, minocycline, or any of those derivatives, your skin or tissue is sensitive to light. So somebody that takes tetracycline and they have staining, when they took the tetracycline and their teeth were exposed to light, that's when they got the staining to appear. All right. Very characteristic appearance. There's mild and there's major. And I'll show you, this is a classic appearance of tetracycline staining. It has bands. The bands are anywhere from gray to yellow. I mean, this is like picture perfect of what tetracycline looks like. You can see how if you go from the cervical aspect of number 9, yeah, let's see, there we go, and all the way down, you see the different colors in it, it bands. And that's what you see in most common cases of tetracycline, a gray-yellow banding. Now, interesting case here, they didn't like their maxillary teeth showing, which that's in the visual zone compared to your lowers. So they got composites on the facial. We call them facial veneer composites, but you can still see the banding on the rest of the posteriors. But look at the color of the anteriors. Anteriors, I mean, the lowers, I mean, they're fantastically developed for that staining. I mean, you see the different coloration in them. And again, that's picture perfect as well. It starts getting a little more severe. Some of the tetracycline staining, bleaching. This is a patient that I used to work with in the community college system. He came over and asked me if I could do anything for it. I said, I'll try something, but I said, I can't guarantee anything. We bleached, we sent him with a home bleach, but we also bleached him chair side. And it made literally no difference. If you look down here, he's also got some gum problems going on. Doesn't have much attached tissue in here. This, you can see his alveolar mucosa. He's going to lose this tissue very, very quickly because of the recession in there. And you get that frenum pulling it. So it's he's got another issue going on. He's the type of guy that really doesn't care though, but he wanted me to try to do something with that. But you can see the coloration, the banding. This is another great case, much, much darker in color. But you see how that gray, yellow banding appears. And you ask, you can always ask the patient your historical diagnosis. Hey, did you ever have any illness where you took tetracycline or any kind of medications that you remember? Do you remember me telling you about that arcing? Now that's bad drawing on my part, but there we go. That's telling you it's developmental. A lot of those things, I don't know why they do it, but you see that arc, right? Has anybody ever seen tetracycline staining? It's pretty common. You would think, I think they still use tetracycline a lot, but so pretty neat.
I have a question.
Yeah.
So we learned about tetracycline as in being used with pregnant women. It's used a lot, but we've never really heard it being used on men. So what would be a reason that somebody that wasn't pregnant would take this to get this?
You have a child with an upper respiratory infection, and male, female really does not matter, as long as when they take the tetracycline during the stages or ages of tooth development, that's when the issue is. So if let's say you take it when you are 12, you have acne and you're very self-conscious of it, so they give you minocycline. They'll tell you, okay, the minocycline will make you photosensitive. So if you go out in the sun, your skin's going to burn real quick. Well, the thing with it, how far developed are your teeth? Your teeth are pretty developed, right? You have all your permanent teeth in by age 12, not including the third molars. So they won't have any effect because the tooth structure is already developed. So it has to be that time period where you're getting your primary crowns developed and your permanent crowns developed. But, pregnancy, you can take it when you're pregnant, if it just depends on your respiratory or medical condition that they want to treat it in. That answer your question?
Yes, thank you.
Yeah, that pregnancy thing, man, I tell you, unfair. You get some more interesting things, which is good for me because I, see some pathology things and gingival conditions when pregnancy happens, when we don't get to see those exciting things on males. At least I haven't seen one. All right. So that is the material on tooth disturbances. We're going to talk about dental caries, pulpitis, and apical inflammation. For your second test, which will open next week, Thursday to Sunday or something like that, it's going to have tooth disturbances and this here. All right. So dental caries. Dental caries is probably the most common disease. We don't consider it a disease, but it actually is a disease process. You have to have certain characteristics for it to occur. All right. The main thing we look at as it's a bacterial infection. You have to have a specific bacteria in the oral cavity for it to occur. And when we look at the bacterial infection, we're going to talk about it. And it's Streptococcus mutans is the primary bacteria that is the issue that causes the caries. And how it causes caries is something called demineralization. All right. We can also call it decalcification. Now, if you remember in tooth development, we looked at the term hypocalcification. We did touch on decalcification or demineralization. The term hypo is referring to developmental, underdeveloped. Okay. Hypocalcification, underdeveloped calcification. Demineralization, you have to keep that straight because it's removal. When you hear the term D, it's removing mineralization. And that's part of the caries process. When we remove minerals from the tooth, we basically destroy tooth structure. We destroy enamel, we destroy dentin, and if it's on the root, we destroy cementum and we destroy dentin. So that's what dental caries is. So the amount of decay somebody gets varies with several different things, but we can definitely see dietary changes increasing or decreasing the amount of caries somebody has. Let's say you eat very healthy and all of a sudden you decide, I'm going to try this sweet tea and soda diet. And, I want to see why people like to drink those things. Well, see what it does to your teeth. Most people, when they're drinking sodas, they drink that soda, but they don't do it over a short period of time. I know a guy that used to drink 3 liters of, the heck was that yellow stuff? Mountain Dew a day. Liters. It's like, how do you even drink a liter, much less 3? So he's chronically bathing his mouth with sugar, but acid. All right. So that dietary change is going to increase the amount of cavities that you see. Let's say you start eating candy and you like the sticky type candy. The stickier it is, the more carious it is because it sticks in your grooves. You got all that sugar sitting in your grooves. Your bacteria are using it. So dietary changes definitely come into play when we look at the amount of decay somebody has. Where we have the advantage of ways to decrease decay. The biggest one that we have ever come up with is fluoride. Fluoride is put in water systems to decrease cavities. And studies have shown that adding fluoridation has decreased cavities by 60%. Now, how many of you all do not have any fillings? Let's see. Oh, you lucky people. Look at it. There's a lot of people that are saying they don't have fillings. And one of those reasons, fluoride. It makes your teeth stronger. Now, fluoride, when it gets into the water system, you drink it, it gets into your circulatory system. You have fluoride nutrients or fluoride minerals floating around. During tooth development, the fluoride incorporates into the tooth structure and it makes it stronger. Optimum fluoride levels is at 1 part per million. Remember, if you have too much fluoride, it's a good and a bad thing. Makes your teeth strong, but makes them not too attractive. All right, so higher than 1 part per million. So that's the big thing, is we can look at fluoride and it dramatically helps. And you're going to be faced with patients that are anti-fluoride, which is okay. That's their belief. All right. But they don't want it because they consider fluoride a poison, and fluoride will kill you. If you ingest too much fluoride, it will kill you. Anytime we give a prescription fluoride to somebody, we tell them, you got to keep this away from your kids. They swallow that, it can kill them. It is a higher dose, even toothpaste. But fluoride is a wonderful thing. The other thing is better oral hygiene. Look at all the things that are out there. Floss, okay, if you don't like to floss. I know you all carry floss with you. All hygienists do. You probably have some right next to you right now. Floss is great, but if you're not a flosser, what about an air flosser, a water pick? Those things are out there. Toothbrushes, all right? Gosh, manual toothbrush, rotary toothbrushes, they're phenomenal. So better oral hygiene has been developed for us to keep caries down. So when we look at developing cavities, the first thing you have to have is a tooth. You are never going to see somebody that wears full dentures have cavities. They ain't got no teeth. You've got to have a tooth. Without a tooth, this conversation's non-existent. All right? They can't get cavities on their denture teeth. Now, they can get plaque on their denture teeth. When we talk about dentures later on, I'm going to show you what I mean by plaque on a denture. You probably have never seen this much plaque, much less on a denture. You also have to have what we call a cariogenic bacteria. Cariogenic bacteria, when we use the cariogenic, it's telling you something responsible for forming cavities. I'll use the term dental caries. I'll use the term decay, caries. I had one student that used to call it rottenness. So I like that. And I'm going to show you cases of rottenness today, and you'll see why that term rottenness goes in pretty well. But you got to have a cariogenic bacteria, a bacteria that causes cavities. The bacteria that is primarily associated with dental caries is Streptococcus mutans. You may hear me call it strep mutans, same difference. All right. So this bacteria gets on tooth structure. So how does it get on tooth structure? So what have you all learned as far as, have you learned about the pellicule? Oh, yeah. Probably in perio. Oh, somewhere in there, or preclinic. All right. So
we talk about it a lot. Oh, sorry.
Go ahead. No, you're fine. Tell me.
I was just say we talked about it a lot right now in our current unit in Ms. Campbell's class.
Okay, good. So the pellicule, sticks on the tooth. Well, it's sticky, so bacteria in the mouth can stick on it, and that's where Streptococcus mutans gets in there. Now, let's say you are the boy in the bubble. When you were born, as soon as you were delivered, they put you in a bubble. And the only exposure you got to humans was they were outside the bubble. They could touch you with gloves, but they never were able to, kiss you or whatever. How can they develop decay? The boy in the bubble? He hasn't been exposed to Streptococcus mutans. So if you don't have this bacteria and you have teeth, you're not going to get cavities. You have to have all four of these things we talk about. So then we have to have a special dietary component. That's the third thing that we need to have. The dietary component is what feeds the bacteria. You all have to have food to live. Well, the bacteria has to have food to live as well. All right. So Streptococcus mutans looks in what you're eating, and they look for fermentable sugars, sucrose. It specifically will utilize sucrose to live. Now, just like you, the more you eat, the more you have to go to the bathroom, right? Common sense. Well, Streptococcus mutans takes the fermentable sugars, it lives, and for lack of a better way to put it, it poops out acid. So it eats the sugars, it poops out acid. It poops out lactic acid. So lactic acid is its waste product. So it lives, it poops, it keeps dividing, multiplying, and all that. Lactic acid, to give you a correlation, your battery in your car has acid in it, right? It is at 0.0 on a pH scale. What's neutral? 7. So very acidic is 0.0. All right. Lactic acid is about 2.4. That's pretty acidic. I wouldn't want it on my skin. All right. When I was, now here's a strange, I do strange things at times. And when I was younger, my sister was learning how to tattoo. She wasn't tattooing like you know a tattoo. She took a pin and would wrap thread around it and dip it in Indian ink. And then she'd go like this, dip it and go like this. Well, she wanted to put a P on my arm for a girl I was dating at the time. This is, see how stupid you are. And I'm stupid enough. I said, sure, go ahead. So she put the P on my arm. I had a little nice little P. Well, of course, you know how this is going to go. Me and P were no longer together. Well, I have a little P on my arm. So I learned about, I was a chemistry major before I went to dental school. And of course, we had all kinds of acids. So I looked at sulfuric acid in a bottle, and it's at 2.75. So it's not as acidic as lactic acid. And I looked at that little P on my arm, and I said, you know, I'm going to get rid of that P. So I took and dabbed some sulfuric acid on my skin, and it was burning a little. So I washed it off, and you never mix water to an acid, and then it really washed it off. It eroded my skin right off. So I thought, you know, 2.75, that's a pretty strong acid. Well, I'm looking at thinking lactic acid is at 2.4. It's even stronger. It tells you that the acidic byproduct that strep mutans is putting out, it will dissolve something. All right. So when you have strep mutans dissolving this by tooth structure, it's continually producing the acid that is sitting on the tooth. So that's the issue with that. Now, to give you some other scenarios, battery acid's at 0. Your stomach acid is at 1 to 3, depending on the day and what you're eating and all that. Lemon juice is 2.4. And soft drinks, 2.5 to 3.5 is their acidic value. So it tells you the more you drink soft drinks, if you're constantly bathing your teeth in it, more acid. Okay. So when they poop out the acid, the lactic acid, it's lowering the pH. That is what causes the demineralization. Low pH will soften tooth structure. So that's what our issue becomes with that.
Quick question.
Yes.
Did you say sulfuric acid gets rid of tattoos?
Don't you dare. No, I said I was stupid and got rid of mine.
I need to get rid of one, and that just sounded like
No.
a great idea.
Oh, no. Let me tell you.
Okay.
You know, I've done some really stupid things and learn from my mistake. The best way to do it is to remove a tattoo. They use lasers now to do it.
It hurts.
Oh yeah, what's that?
It hurts.
Oh, what do you think that damn acid did? That acid really, I mean, and it was only the size of a quarter. Let me tell you,
God.
when I put the acid on, it wasn't bad. It's when I stuck it under the water, then, and I still have a little scars, but every time I see that, it's like, you just
okay.
No, everybody heard that, right? Do not put acid. There's no disclosure. So all this comes into play, but you got to have time for all this to work. It's not like saying you drink something, instant cavity. Time takes to demineralize. Typically, a cavity in a normal scenario takes anywhere from 18 months to maybe 3-4 years to form. That's how slow it is. But you got to remember, it's continuous. It's a slow process. All right. So that's what we look at. When you have all 4 of these, you end up having decay. Okay. If you can remove any of these, you break the cycle. And that's why, you know, a lot of you have good oral hygiene. You're probably not drinking Mountain Dew all the time. So something in here is not in the cycle. So that's great. And that's what helps. Other things do come into play. Your shape of your tooth. In tooth anatomy, you remember the names of all those grooves? Oh my gosh, yeah. Well, that's the more grooves you have, the more issues you can have. The more anatomy your teeth have, the more pits and fissures that bacteria sit in. All right. So that oral hygiene. A lot of these young kids that drink a lot of Mountain Dew, you look in their mouth, there are cavities everywhere. Their oral hygiene stinks. It's horrible. Young males are just, they're disgusting. They don't pick up toothbrushes. And it's like, hey, do you have a girlfriend? I mean, I was in one time and this assistant was asking the kid, he was probably 15. She goes, how does your girlfriend kiss you? There's no way, you know? And it's like, she was all up in his mess, but he just doesn't brush. Also, your saliva. You all know that your salivary secretions help buffer the oral pH. So when you drink or eat and your pH of your mouth lowers, your saliva helps raise it back to normal. So those things come into play. And when we also talk about saliva, what about if you have a dry mouth? You don't have any saliva, you have xerostomia. How is your buffering capacity going to be when we talk about caries development? So why do we tell the patient brush? You know, sure, we want them to brush because it buys more dental products. We're going to be selling dental products in our offices, but why do you tell them to brush? What's the object of brushing?
Removal of biofilm?
Yeah, remove biofilm. If you remove the biofilm, where's the bacteria? You've removed it. Now, how quick does it form again? Pretty quick, don't you think? Why do you brush 3 times a day? To remove the biofilm. And you're going to see I had a little kid in last week in an office. I asked him, how often do you brush? Well, when I think about it, maybe once a day. And I'm thinking, when you think about it, okay, so that's telling me he brushes probably once every 3 days. So demineralization, we use the term demineralization as the removal of minerals from tooth structure. It's what we classify as a dynamic process. When I use the term dynamic process, what it's doing is it is fluctuating. The tooth will demineralize, but it turns around and remineralizes. We drink things or acids or whatever get exposed, it demineralizes. Now, when I use the term demineralization, I'm talking about the outer layer of enamel or the outer layer of cementum, all right? I'm not talking about the inner layers, very, very outer. So if you take a stack of papers and you have them stacked one on top of each other like this, the outer surface is going to be the one that is affected first. All right, so we demineralize the outer layer. We remove some of the inorganic minerals from the outer layer. It makes it soft. That's demineralization. How it occurs? Exposure to acid. The bacteria make acid, okay? So you drink your Mountain Dew, you drink a liter of it. Suppose then you turn around and flush your mouth with water. What have you done with the acid? You've removed it. When you eat, your pH in your mouth goes down because of all the bacteria utilizing the food, making more acid. All right. What does your saliva do? It starts getting thicker. It flushes. When it flushes, it's causing remineralization. All right. So does that make sense as far as dynamic? So the demineralization, the local demineralization on the tooth structure is by the lactic acid being produced by strep mutans. The remineralization is the oral pH raises up back to where it should be, and lots of variation. You could rinse your mouth out with water. The pH raises because of salivary secretions, and that's why we see it going in a balance, all right? The problem becomes, suppose you keep demineralizing and not remineralizing. That's when we have more demineralization or decay. So when we look at cavities, where do we see caries? Dental cavities, rottenness, whatever. Pits and fissures are the most common areas that we will see them, all right? So when you look at, they say that studies have shown, I don't know, to me it always seems like lowers have more cavities, but studies have shown most decays on maxillary, yet everything sits in the mouth. Lowers have more calculus, things like that, but salivary glands, but that's supposedly what it tells you. Molars have more cavities. Why? More grooves, okay? When you look at, cavities, 90% occur in the pits and fissures, okay? And about 50% of the cavities in the children are on the pits and fissures. So that's where the primary location is. How we detect decay on those surfaces, one, we use tactile, meaning the explorer. We use the pointy little tine on the end, and that's what most people are comfortable with, is using that tine. The rule of thumb nowadays, people are starting to get away from using the explorer as much. They're not trying to poke through, because you can introduce bacteria deeper. So that's why they're trying to stay away from it. But that's the main thing that everybody picks up. The other thing is visual. You can look around and see decay. Do you all wear loops? Let me tell you, the loops, oh my gosh, phenomenal. You'll see things in there that you're like, oh my goodness, I can almost see your feet with these things. They're fantastic. The light, if you have a light on your loops, the light helps you see. But the other thing that we also use in clinical practice is radiographs. Radiographs can show you things that your little eyeballs and your Explorer can't find. There's some other things that you can detect with. There's something called a diagnodent. I don't know if you all have this at the school. Some schools use it, some don't. You use this handheld meter. You go over the groove, you calibrate it, then you run the little probe over the tooth structure, and it gives you a reading. It's pretty accurate as far as telling you, is decay evident in that tooth? So it's a pretty nice little laser beam that sends down a laser and it's reflected back and it gives you a reading. They also have fiber optics that they use. It's basically a very fancy high intensity light. If you look at the image in the mirror, you see the little triangle. Well, visually, you may not be able to see it. This light will cause the change visually for you. So it's another handheld thing. The diagnodent is pretty expensive, a couple $1,000. I think it's about $3,500. These trans aluminum lights are a couple $100, $200-300. So it's not too bad. So good ways to help clinically. But we'll show you some clinical pictures. You know, show and tell is always great because it at least shows you thing. This is showing you your premolars, and you can see the grooves and the pits and the fissures. That's the most common area you're going to see. And the more anatomy on the tooth, the more you're going to see it. How you're going to check this? Visually, but you're going to feel it with the tine of the Explorer. Occlusal caries on x-rays may not show until it's a good size. We use bite wings to pick up decay interproximally because that's where we can't see. To see occlusal decay on a bite wing, it's got to be bigger. These small little incipient lesions, it's not going to be seen. This is a hole. That's a big hole. X-ray, I don't need an x-ray to tell you that's a hole. But when I see it on the x-ray, I'm going to see that occlusal. It's big. This was a picture. It was a kid that had a BB gun, and I took the x-ray. I got to find the x-ray somewhere. And I saw this round ball inside his tooth, and I'm like, what the heck is that? You know, I'm like looking. And so we drilled it. And I took some cutting forceps, pulled out. It was a round ball. And I'm like, I look at the kid. I said, what is this? He put BBs in his mouth because his mother came around the corner. He wasn't supposed to have a BB gun. So he put the BBs in his mouth. And one of them happened to go inside the hole. So it's like, oh, okay. So that explained what the round, perfect round ball was. Good hole in one too. Some other locations of cavities. Smooth surfaces. Smooth surfaces are what we classify as smooth. There's no pits, fissures. So interproximals, all right, mesial, distal, those surfaces. Cervical, all right. Think about where your gingiva touches your tooth. That marginal gingiva, or the gingival margin, that is a cervical surface. It's very smooth. All right. Cuss tips. Cuss tips are a weird one. It's pointy, but you can find cavities on cuss tips. It's the strangest looking thing that you'll see. So let's show you some pictures and then we'll give you a break. All right. What side of the mouth is this? You got two choices, right or left?
Right. The right.
All right, everybody good? It's the right. Okay. You think you know your right from your left, don't you? But it gets confusing at times. So what tooth number is this? At least
30.
What's that?
30.
That is 30. At least I'm not showing you. Ooh, that dog's answer was something. But at least I'm not showing you primaries. Primaries, ooh. But if you look at the x-ray, do you see the cavity? Do you see the triangle here? And then all of a sudden it's like, ooh, that's what it does. It goes in like a triangle where it has demineralized the enamel. Once it hits the DEJ, it goes and spreads quickly. And the reason why it does that is look at the hard tissue or the hydroxyapatite in enamel versus dentin. It can definitely go through dentin quicker. All right. What side of the mouth?
Left.
Good. All right. You're okay. Everybody okay with left? I hope so. If you're all right. This is number 17, 18, and therefore that must be 19. They do have bone issues. Do you see the level of the bone? They have furcation showing. All right. A little bit of calculus here, little here. But look at what this third molar has helped create. By having that tooth lean, it helps hide bacteria. And this is the problem with third molars that are butting up on another tooth. You can definitely get decay. Now, look at where the tooth structure, this is your enamel would come down like this. So it goes through the enamel, goes into dentin, but it also can go at the cementum to the dentin and go through a lot quicker. When we talk about cervical decay, this is an example of cervical decay. It is on smooth surface, and at that gingival margin, that cavity, we see it as this, but 2 to 1, it's like that as well. So it gets a lot harder to fix. When we talk about occlusal cusp tips, and you can see a little dot here, you start thinking, okay, attrition is one thing, but you can get little pinholes up there on a cusp tip. And have you all talked about class 1, 2, 3, 4, and 5's Caries lesions? Did they talk to you about class 6? A lot of them don't. Class 6 is on cusp tips. So class 1 is like the occlusals, is an example, lingual pit. Class 2, interproximals. Class 3, interproximal of an anterior. 4, like an incisal angle, like a MI, you kiss the pavement and it breaks your tooth. And then a 5, and then a 6. Does that come back to memory somewhere? I hope, maybe. Okay. If not, tough luck. Okay. All right. Let's take a break. We'll go 10 minutes. When you come back, we will talk about different lesions or excuse me, my brain, caries, cavities that we have. As you can see, there's quite a few. Let's get this camera thing going. All right. You'll hear the term incipient decay. Incipient is telling you it's decay that's still within the enamel. So it's demineralized the enamel, but hasn't broken past the DEJ. So these are early cavities. Nice thing about incipient decay, if you ever are said or tell a patient you have a watch area is probably telling you see something on the x-ray, but nothing to treat. You can remineralize these with prescription fluoride. So incipients are just very, very tiny. When we look at the x-ray, this is showing you tooth number 29. If you look at number 29 here, you'll see this area here. All right, that is an incipient lesion. It hasn't broken past the DEJ. So we put it as a watch area, and hopefully if the patient is using a prescription fluoride, it takes care of it. Cavities typically occur what we call a kissing lesion. If you get one on this side, you have a high chance of getting one on that side. This is the most common cavity that we have. It's slowly progressing. It typically takes 18 months to 4 years to form. It's the normal decay process. It is a slow but continuous progression. So you go from the incipient and it continues and basically goes into the dentin. Rampant decay, this is what that student would call rottenness. Rampant decay is severe decay that involves multiple surfaces. It may involve the mesial, the facial, the lingual, all right, or as you see shortly, a lot of surfaces. What we basically look at rampant decay, we see it associated with very poor oral hygiene. They are exposed to sweetened fluids or acidic drinks, sweet tea, sodas, either one or both. The oral hygiene, again, the 15-year-old I was telling he doesn't brush. Well, that's an example. He drinks acidic and sweet tea all the time. The other thing we also see is with xerostomia. If you have a dry mouth, you don't have that buffering capability. If you've ever heard the term meth mouth, methamphetamine is a pretty acidic drug, and it will help destroy tooth structure. The other thing is people that are using meth really don't care about their oral hygiene, so that doesn't help as well. But this is an example of rampant decay. You can see multiple areas that are broken down on many teeth. This is another example, and this is a patient that definitely had meth mouth coming in, and pretty good sized holes. And unfortunately, some of these holes are too big to even fix. And here we have a child with pretty severe decay. These are primary teeth, letters K, L, and M. So if you figure this is on one side, you can also figure it's pretty much elsewhere as well. But those are examples of rampant decay. All right, so now when we look at root caries is on the cervical, whether it's on the facial or the lingual. It's definitely more common on the facial cervicals, but you will see it on the lingual surfaces as well. The problem when we see root caries, you have to remember during anatomy, when you are learning about enamel on the cervical aspect does this, and then you have root structure. So you have less enamel at the CEJ area because it's tapering away. So when you look at exposed cementum, cementum's a hard tissue. It's 50% hydroxyapatite. The problem is when you have 50% versus 96% being exposed to acid, the 50% will demineralize earlier than the 96%. So acids basically have to be exposed on enamel longer because it's a hard tissue difference. So cementum, again, when you look at demineralization, it will take less acid to demineralize it because it is not as hard as enamel. What we do see with root caries, one, if somebody's not brushing well, that's mainly where you're going to see it, but you tend to see pit and fissure caries, interproximal decay in younger people. As you get older, you start seeing more root decay. And the reason being, they start getting xerostomia. All right. The patient's physiological makeup is going to change. Their salivary secretions as they get older don't function the same. All right. So you don't get that buffering capacity. The other thing is, what do you know that as you go older, you can expect to be on some medications? Most medications, a side effect is xerostomia. So add decreased salivary flow, add xerostomia to it. Now you have a dry mouth. The other thing is, as you get older, you're not going to be able to exhibit the same manual dexterity. You can't use your hands the same. You may have arthritis. You all will learn that suppose you have a patient with severe arthritis and they can't bend their fingers more than this. How are they going to hold a toothbrush? Good luck. So what you have to do is you modify your toothbrush so your toothbrush could be a tennis ball. You cut a hole in a tennis ball so the toothbrush could fit in. Now they can take and brush their teeth a little easier because they can close their hands on that. So those are tricks that you will learn. This is the one we showed you about the root decay. This is another example of root decay. And you can see that the gingiva associated with those teeth is definitely inflamed. That's because it's just all filled with bacteria in those areas. And there's also different bacteria that come into play with root decay. Instead of strep mutans, even though it's present, it's not the prominent with root decay. We tend to see lactobacillus type things come up. So you got a different bacteria to play with now. We use the term recurrent decay. You have a tooth that was previously restored, whether there was a filling, a sealant, a crown, something like that. You get a cavity under it. So when we look at this patient here, we're looking at tooth number 19. I'll let you find 19 first. All right, so 19, if you haven't found it, is here. So you have a filling. We classify that as a DO. DO composite. You notice the opacity, it's radio opaque, but it's not the same whiteness as this. This is metal. This is composite, which is kind of like a resin. All right. So when we look at the recurrent decay, do you see the cavity that's underneath it? That's recurrent. This here is recurrent. This is a little harder to see, but you can see some darkness in there, and I'll erase so you can look at it again. All right. So those are examples of recurrent decay. And 2 to 1, there's some here and associated with restorative. So what is this?
Is it overhang?
This is a PFM crown. Have y'all talked about restorative materials yet? But this is a crown. You can see the outline shape. They put porcelain, which is a glass, looks like enamel, fuse it or melt it to metal. And that's the way that it appears on a radiograph. All right. Do you see the recurrent decay? Couple areas, to say the least. All right. On this tooth, huge recurrent decay. 2 to 1, this is going to need a root canal. This tooth and this. So what tooth number is that?
The bottom one?
No, that one right there. I know I've got that bad question mark.
Oh, 4.
Oh, wonderful. 4. Yeah, good. Do you know what this is?
Is it from a root canal? The things they stick up in there and cut off? I'm not sure the name of them.
Is it a post?
Root canal. If you ever see a root canal, and I'll make sure you'll see it in the pulp and it goes all the way down. This is a pin. So this is probably a MODB or some large amalgam. And to get the amalgam, you all remember line angles. So if you have a line angle here, like a point angle, if I can get there, like these on the side corners of the teeth where 3 surfaces touch, if this tooth is part of the tooth is missing, they put a pin, you drill a hole, put a little pin in so the pin sticks up. It allows the filling material to grip to it. So that's what that is. That's a pin. Arrested decay. This is not the one that went down to the bar and got drunk and got arrested. This is decay that stopped because it was able to remineralize. All right. So it got into the dentin, the decay did, but it got exposed to high amounts of fluoride and it remineralized. How we see it is we look at the tooth, they're missing a lot of tooth structure, but when you take an explorer or an instrument, all this is actually brick hard. Sometimes when I take that explorer, it will feel sticky. I push in, when I pull out, it's almost the same as if you do this. You have that feel, all right? Another way I can do it, I have a miniature spoon. Anybody that's an assistant knows what a spoon excavator is. It's a little miniature spoon, and I can scrape stuff out. Well, when I scrape this, it's rock hard. So that is arrested decay. And this is another example. What's that?
Would you leave the arrested decay or would you still go in?
Yeah, you know, it's funny. This is an example. We are doing restorative here on this premolar and molar. The premolar, you see, we basically are going to put in an MO. We cut it in this shape and we cut a box. So the box, if I look at it on an x-ray, it looks like that. Okay. And this is arrested decay. When I went in there, it's rock hard. So I left it and I restored over it. Now, do you notice the different colors? What color is that? It's yellowish. That's dentin. So you can see the different colors. Do you see the DEJ? So your enamel and your dentin. So that's what's neat when you prep teeth. You can actually see things like that. Nursing bottle caries, baby bottle caries, nursing bottle decay, however you like to call it. This occurs when you have an infant using a bottle at night to go to sleep, and the parents have placed some sort of liquid in the bottle, and the liquid is sweet. Could be milk, could be sweet tea. I hope they're not giving them Coke. I don't know. Maybe they give them Coke. Well, we give them Diet Coke. Okay, we're worried about the baby's weight. But it constantly bathes the mouth with sweetened fluid. Well, strep mutans loves it. It says, ooh, I'm going to eat all this sweetener that you're giving me, and I'm going to poop out more acid. Well, the reason what we see it on is we tend, the majority of the time, we're going to see it on the maxillary anterior teeth. And you see bombed out teeth that look like this. Look at the lower anterior. They look kind of nice, don't they? Now, This one over here on the right side is not as attractive. But then again, this is starting to get to the posteriors. But the anteriors that you see here are involved. And the reason why we don't see it on lowers, the tongue protects them. So when you're nursing on a bottle like that, your tongue is sitting over the lowers and it's not being constantly bathed in fluid. So that's why we see the majority of it maxillary anteriors. These are some other examples. You can see those little nubs up there. The caries got rid of it, the whole root structure. So the whole crown. Now you already got those little nubby roots. And then you'll see this one. They took this one out earlier. You still got these little nubbies. And then you'll hear the mother say, well, I don't want my child not to have teeth in the front. And you're like looking at her like, these aren't teeth in the front. And the reason why you take them out is you don't want them to abscess up. Another one. So those are some of the root decay that we, or nursing bottle decay that we see. The last one is radiation caries. Radiation caries is a type of rampant decay. If you remember, the rampant decay had caries everywhere. Well, this occurs post-radiation therapy. So if a person goes in for head and neck radiation, they have an oral cancer, they have to irradiate it to help kill or shrink the tumor. Well, if the X-ray beam passes through a salivary gland, radiation kills tumors, but it also kills healthy tissue as well. So if it passes through a salivary gland, it will kill the salivary gland cells. If you kill the salivary gland cells, what happens? Xerostomia. So when we look at radiation therapy, radiation is good because it kills cancer cells, but it also kills healthy cells as well. So when we kill the healthy cells of the salivary glands, if the beam is in, or if the salivary gland is in the exposure of the beam, we get xerostomia, because if you have no cells to create saliva, you're going to have a dry mouth. When we do that, when you have a dry mouth, it dramatically changes the bacteria that's present in your mouth. So you have more bacteria because they're not being flushed away by the salivary secretions. All right. The other thing is your mouth becomes more acidic because you have no saliva to buffer it. So by becoming acidic, the pH of the mouth lowers and you end up with specialized radiation caries. So this is an example of radiation caries. Radiation caries starts on the cervical aspect of the tooth or involved teeth. As you can see, there's multiple. So anytime somebody undergoes radiation for head and neck cancer, they will have bombed out teeth removed before the radiation. And when we talk about cancer, we'll talk about why you do that kind of thing and all that. But it happens at the cervical. Once it's at the cervical, you know, it can extend or expand. And that's what you see here. Pretty devastating. And then trying to remove these post-radiation is not an easy task, because it tends to have issues with healing and how the bone reacts to radiation as well. This is an example. Take a look at these teeth on the Panorex. You'll see in the upper right, There is a root tip, no crown. Over here, you'll see abscess or granuloma. All right. Let me erase this once I find my eraser. Okay, come on, eraser. Well, maybe not going to erase for me. Now look at this. They had to put some sort of metal bracing in because of fracture. Now look at the patient. This is radiation caries. They had to remove some teeth on this person, and pretty much they got little nubs left. All right. So when we talk about forming decay, how a cavity forms, it always starts with an incipient lesion. If you don't have remineralization of the incipient lesion and you let it go, it enlarges. That's what we classify as untreated. So we will talk about all these and the steps of it. So the formation of the incipient lesion. So imagine that you have bacteria adhered to your teeth. They're eating the sucrose, and their byproduct is lactic acid. The lactic acid is demineralizing the outer surface of the enamel. The stack of papers that you have, it touches that outer surface. So as it kind of softens the outer enamel surface, that's what we call an incipient lesion. So what we see clinically, I can see demineralization on a tooth. I can see them on the facial easier than the interproximal. All right. So when we see these white spots or demineralized areas on the facial or the interproximal, they're reversible. How I can get them reversing is making sure that patient is taking good care of their teeth and making sure they're using fluoride. If I see a lot of demineralization, I may prescribe a prescription fluoride. When they're using the prescription fluoride, it's a dramatic difference in the amount of fluoride they're getting. I can remineralize the softer outer layers, so I can arrest it. So where you would see demineralized areas are where the patient fails to brush or floss. Cervicals. Do you remember hypocalcification? Hypocalcification, white spots. White spots are, or one thing. The location of them is going to tell you demineralization as well as hypocalcification. Demineralization, look at the cervical aspect, look at the contacts. All right. These are demineralized areas because this is where plaque will form. Hypo, you tend to see them on smooth surfaces. You can see them in pits and fissures, but they have been there a long period of time because they occurred during tooth development. Lots of demineralization. Look at the canine, tooth number 11. Big, wide demineralization. That's going to be a big problem if they don't take care of this thing. Now, look at this. Does that look different than, say, this area? Yeah, this is a cavity. The enamel demineralized and chipped away. They're stuck with a cavity. So that demineralized area could not remineralize now. It's when you get that frosted looking chalky appearance. So this, yes.
Color?
What's that?
Why is the tooth that color? The one that has that cavity.
you know, they probably got a lot of stuff going on in here, but yeah, this shade here, now this is a large restoration. It would not surprise me that the tooth is dead because the size of this filling, you got to figure the nerve is somewhere in here. So that's why you're getting that gray appearance. But that's something you just picked on, something that you clinically, if you saw that discolorization, take an x-ray. That tells you just by that visual appearance, something's not right. So you take an x-ray. 29, this is one we looked at earlier. This is an incipient lesion. You can remineralize it. It's harder to get to with the fluoride, but you can do it. I have a couple cavities, incipient lesions like this, and they've been like that for probably 2 to 3 years because I'm using fluoride as a prescription. Demineralized areas, you can see on the molar on the far left, that distal molar is different than the demineralized area with the large silver filling. Demineralized areas are soft. They will stain much, much quicker. Doesn't mean you have to fill it yet. I kind of see if it's still intact structure. This is something called cavitation. This, you'll notice it kind of looks frosted here. And you see a hole here. This, I could take my Explorer, push on it, I just crack it. So think about if you're digging a tunnel under the ground. You go, you're under the ground, you know you have a thin layer of dirt above you. That's what cavitation is. It's undermining the enamel as the cavity gets bigger. So what happens if you're in that tunnel and your buddies walk over the top of it? All of a sudden it crushes. That's what happens. So cavitation is undermining the enamel. That's what it looks like on an anterior tooth. It's telling you it's no longer an incipient lesion. It's getting bigger. This is what it looks like on a posterior. So this area you see here had a thin layer of enamel bridging across. Well, all of a sudden, the cavitation roof collapsed. Now you got an open area. So this is what happens when you have an incipient lesion. So if we take and blow up that little area, we get a small area of demineralization. That's an incipient lesion. You notice it's still in the enamel. So as this progresses, if it doesn't remineralize, it gets bigger. It's still incipient. It's in the enamel. So it then hits the DEJ. Once it hits the DEJ, that's your DEJ if you don't remember anatomy, but there we go. It starts getting bigger. It crosses that DEJ and then can spread dramatically faster because dentin is 70% hydroxyapatite or inorganic mineral. So this is what happens. It gets larger and larger. And as it gets larger, it removes more tooth structure and it keeps encroaching the pulp. Okay. So this is an example of you have areas of demineralization. You can see the white chalky. It's pretty broad. It's on the canine, but it's also on the lateral incisor at the cervical. The canine, you see that nice color underneath? It's telling you it's into the dentin. So you're going to take an instrument and you can scoop out soft areas. And do you notice the gingival inflammation around that? I mean, that's all that bacteria that you have in there, you know, with that caries process is helping with your periodontal or your gingival process as well. This is the other side of the same patient. This is showing you when you do a filling, they have pit and fissure decay. So you go in there and you start cutting the prep and making it bigger. But look at the color of this. And then look at this. Do you notice what the color is telling me? I'm sitting right over the pulp. I go any further, I'm in the pulp. Now, this is a pulp horn. Yep, snap. Hold on, where'd I go? This is bad driving. Okay, there we go. That's a pulp horn. You remember about the pulp horns? They go up on the corners or the cuss tips. Well, I exposed into the pulp horn. So they need root canal. All right. So when we have an untreated cavity, it gets bigger. All right. It is chalky white. It stains. It breaks the outer surface. So that's what we've talked about and shown you pictures of. This is showing you something you can see clinically. So this is a primary tooth. We look for color change. So you may be able to see this. Do you see the darkness in that area? I'm going to verify it with a radiograph, but that's what I can see interproximally. There's a cavity there. So this one here, look at the premolar, look at the mesial from the distal. Here's your mesial, here's your distal. Do you notice the color is different? So when I take an X-ray, that's my cavity. So my X-ray shows me it, and now I can verify it with my clinical. It's great when you see both, because then you know it is there. So that's what you can see sometimes clinically. X-ray wise, bite wing really gives me the view. That color difference, it takes a while to perfect color change, noticing it clinically on a patient. All right. So do you see decay anywhere?
One, is it right there by the mandibular first molar?
Yes.
Or
All right. So 2 to 1, this is incipient here. This one's getting good size. It looks like it's touched the DEJ and gone through. So it's been untreated. All right. So if you've ever had a cavity, some of the symptoms you may experience, some people don't have any symptoms, and symptoms vary between patients. To me, it's the oddest thing. The smaller the cavity, the more sensitivity they have. It's like you got a big hole in there and you're like, does it hurt? No. And it's like, really? And then you got somebody that comes in with this small little cavity and they're like, oh my gosh, I can't eat my sweets anymore. It hurts. So the most common sensitivities we hear from the patient is they're sensitive to cold, they're sensitive to hot, or sweets. So, and again, it varies. We use the term pulpitis. Pulpitis is inflammation of the pulp. All right. You can have pulpitis. It's inflamed. It's undergoing the cardinal signs of inflammation, even though we can't see it, physically see it, but we know it's inflammation. If you don't treat a tooth and it has decay and it gets into the dentin, is an example of pulpitis, they start getting sensitivity. I can put a filling in and you have sensitivity after the filling was placed. That's pulpitis. You have inflammation of the pulp. The pulp wasn't really thrilled about you going in there and playing near it. All right. And then with pulpitis, again, we're going to inflame the pulp. We're going to see sensitivity. We have 2 different types of pulpitis. we have reversible and we have irreversible. Reversible tells me that the patient's sensitivity is going to decrease over time. Perfect example. You come in, you have a cavity, we fill it. After the filling and the numbness wears off, and for a couple weeks, you're like, man, every time I drink cold, ooh, that's cold. All right. And then as time goes on, it goes away. That's reversible. The reason why it went away, have you heard of reparative dentin? The odontoblasts that are on the outside of the pulp, the outside periphery that are right next to the dentin, created reparative dentin. It takes time, so it builds an insulating layer and makes the pulp happy. Irreversible pulpitis, their sensitivity never goes away. In fact, it probably progresses. So you put in a filling, you tell the patient, you know, that was a deep filling. That was almost down there to the feet of your teeth. And we got real close to the nerve. Well, we're going to see how it goes. Well, they have pain with it, sensitivity, and it basically progresses and never goes away. That's irreversible pulpitis. Pulp necrosis sounds exactly what it is. You got a dead tooth. All right. When you have a dead tooth, it's telling you, if I take, we have what we call an EPT tester. It's not the early pregnancy tester. It's the electric pulp tester. We put a little current on the tooth, and we basically, when we send the current through the tooth, the person says, I feel that current. Basically, what we're doing is shocking the tooth. A dead tooth does not shock. We can go all the way up to 10 or 100 if your meter goes to 100 and nothing is felt. We call that a non-vital or dead tooth. All right. So teeth are normally vital. They're alive. If you want to test this, I can give you homework. Go to Cold Stone Creamery. I want you to go in, order something. I don't care. You can choose what you want. When you get the thing in a cone, take it and cram it on 8 and 9. Just stick it right there, right in front of them, and let them watch you. See what your teeth do. Your teeth, if you don't have root canals, you're not going to like the feeling. Well, that's telling you your teeth are alive. If you had dead teeth and did that, they would sit there and think, oh my gosh, that person's nuts, for one, but you wouldn't feel anything because it's dead. When it's dead, you don't feel anything. It's asymptomatic. In some dead teeth, you can see colors change of the crown. And when we were talking about tooth number 10 before, why is the color different? 2 to 1, it's a dead tooth. So these are examples of dead teeth. We look at the patient and we say, that tooth is definitely a different color. We're going to take an x-ray. All right. So both of them are dead. If I put an electrode on there, that EPT tester, it's going to read 0. They don't feel anything. It's dead. That's dead. Dead as a doornail. You can tell they bleached the other teeth, hoping to bleach the one. Now, what do you notice at the apex of the dead tooth? Do you see this periapical radiolucency? That is associated with dead teeth. That's what we call a granuloma. We'll talk about granulomas more at the end of the semester. We use the term abscess in different manners. A periapical abscess is what we classify as an acute infection spreading from a dead tooth into the periapical region. So what it's telling you is it's acute. It's symptomatic. Remember, acute pain versus chronic pain. All right. Acute scenarios are very quick onset. All right. So what happens is you have a dead tooth, whether it was traumatized, recurrent decay, for some odd reason, the pulp just died. When the pulp dies, the decayed dead pulp, all that bacteria in there go out the apex. All right. The bacteria are out the apex. Their acid byproducts are out the apex. So that's now involving the periapical region. So it becomes abscess. This is what we call a hot tooth. All right. It's not a Brad Pitt tooth. It's a hot tooth, meaning it hurts. You know, you tap on that tooth or the patient bites down. It's like, holy moly. And then you're going to go, patient says, oh, I got a tooth that's bothering me. It's this one right here. And what do you want to do? You want to tap on it. Is it this one here? I told you it was that one there. You tap on it and you watch them raise out of the chair. I guess it was that tooth. That's a hot tooth. All right. The problem with this, if you look at the end of the apex, that's what's sensitive. It can spread into the bone. So that's what an abscess can do. When we look at this hot tooth, all right, the tooth is non-vital. It's dead. All right. Why we have a dead tooth? Decay, trauma. Remember, decay could be rampant decay. And again, that person with all those ugly teeth that you saw in rampant decay, those teeth, believe it or not, didn't bother them. All right. But you'll get lucky or unlucky. You'll get scenarios where the decay is bothersome. All right. The tooth is tender to percussion. If a patient comes in and says, I have a sensitive tooth, we take the back end of a mirror handle and we tap on teeth near it. And you say, okay, does this tooth hurt? Does this tooth hurt? And you know which tooth is going to hurt. And as soon as you touch it, yeah, that's it. Okay, now you know which tooth it is. All right. Sensitive to percussion. They may or may not have cold sensitivities. Most of the time, when you have the periapical being inflamed, all that inflammation slightly raises the tooth. So when it's slightly raised, if they bite, it crams down on the periapical. That's what hurts. So patient will tell you they can't chew on it. Whenever they close their teeth, it hurts. When you tap on it, you'll raise them out of the chair. Sometimes you get some swollen lymph nodes, lymphadenopathy. So the side of the tooth, the side of the mouth the tooth is on, they may have swollen lymph nodes. Radiographic changes, you may not see any. Chronic scenarios are when you see radiographic changes. Acute, you may not see it. Now, you can have a chronic scenario flare up, and then you have acute. This is a chronic scenario. So a chronic scenario is when you have what we call a granuloma. Some people like to call it periapical cyst. Remember, periapical abscess is hot. A periapical cyst, it's chronic. Basically, it has no pain with it. When you see these on an x-ray, you're going to tell the patient you have an abscessed tooth. And they'll say, well, if it's abscess, why doesn't it hurt? You can tell them you're lucky. The problem is a chronic can flare up and create an acute scenario. So you can always have chronic, no pain, and one day on a 3-day holiday when all the dental offices are closed, it flares up and they have pain. So what do we see with clinical findings of a granuloma or periapical cyst? Tooth is dead, decay trauma, it's asymptomatic, and we will see a change on the x-ray. So the difference between a periapical abscess and a periapical cyst, they're both dead. They have a reason why they're dead. One is symptomatic, one is not. One, you may see radiographic changes, you may not. The other, you will. So good comparison. This is a dead tooth. They have an existing restoration in it. That's what the little area here is. Periapical area, you see a radiolucency. That, I would tell the patient, is an abscess. They'll say, I have no pain. I'll say, you're lucky. What I'll tell you is this is a granuloma. If I told the patient you got a granuloma, they'll say, a granula what? So that's why we use the term abscess. Now, it may not hurt now, but one day it could wake up and they have a lot of pain. Nice little abscess. It's a granuloma or periapical cyst. Basically, they have no crown on the tooth. This is a nice case because it's showing you clinical as well as radiographic. They see a swelling on the outside of the tissue. Look at that. Look how deep the filling is. Pulp horn. So it's sitting right there. Cellulitis. Cellulitis is when you have an abscess that spreads. We told you that the periapical abscess involves the periapical or the root tip. That infection can all of a sudden spread into the surrounding tissues. If I have, say, number 30, and it has an abscess tooth, if that infection spreads, it becomes more diffuse, it's spread out. Well, it gets into my soft tissues. It can leave the bone and get into soft tissues. Most commonly, we're going to see it with abscess teeth, and we're going to see it with third molars. What we see clinically, diffuse warm swelling. We feel it. It feels hot. All right. It is big. It can even spread further. All right. So we get a little bit of swelling. We start getting a lot of swelling. You touch this and they will tell you it hurts. It's all under pressure. All right. Elevated temperature. You can feel it's warm, but if you take their temperature, you're also going to notice they have an elevated temp. These are examples of cellulitis, dental origin. Nice puffy lip, maxilla, kind of nice, isn't it? You notice where he is? Hospital. Pretty big cellulitis. So cellulitis, that infection has spread into the soft tissues. Some of these can be life-threatening. Some associated terms that we talk about when we talk about abscess teeth: sinus tract, a sinus tract, and a fistula. The sinus tract is a channel within the tissue. Think about if I had a miniature straw that went from the tooth to the outside of your face. That's a sinus tract. The fistula is the outside opening. All right. So imagine a straw going from the apex through the bone to the soft tissue. All right. That's what you are seeing when we talk about fistula and sinus tract. These are fistulas. They crust over, but they don't heal because they are chronic. I have done some when I was in public health that I could take an instrument into the fistula and go into the sinus tract and scrape all the way to the tooth. This is a nice one. Some of them will drain pus. Nice, isn't it? Those are the kind that you want to squeeze and get out all the infection. And a lot of times if you take an instrument up that sinus tract, once you get to that abscessed area, when you remove your instrument, it will flow a lot of pus out. The most pus I've ever gotten out, I was able to fill a shot glass. That's a lot of pus. The last two things we'll talk about, Ludwig's. Ludwig's angina is cellulitis from a lower that has spread to the submandibular area. It's life-threatening because if it spreads, it constricts breathing. That's Ludwig's angina. Floor of the mouth, underside of the tongue. So extreme cellulitis. We can get them from dental infections, and some of them are pretty nasty. These are the people that go in the hospital, and these are the people that end up in ICU. Abscessed teeth, third molars. Pericornitis. Have you all heard of pericornitis? If you have wisdom teeth that are covered by gum, that gum gets infected. That's pericornitis. Bacteria that are involved. Remember we were talking about strep mutans. That's a wimpy bacteria. When you get cellulitis and big swellings, anaerobic bacteria. These are nasty bacteria. They live without oxygen. Swelling, neck, pain, fever, raising of the tongue. Just be comfortable with, you know what Ludwig's angina is. But I'm giving you some examples of what you will see on the patient. This is Ludwig's. He's in the hospital. You notice how his tongue is protruded? So that is all swelling from dental. Look at the tongue. That's the ventral surface you're seeing. They put drains, rubber tubes, into the infected area and suture them so it constantly gets air to kill the bacteria and drain out. This is her cute picture on the right. This is her in the hospital. Third molars. Look at the drains. Lucky to be alive. The last area we'll talk about, cavernous sinus thrombosis. This is Ludwig's angina for an upper. All right. This is cellulitis, upper teeth. The cellulitis and the septic bacteria have basically reached the brain. You don't see these that often, thank goodness. Very poor prognosis when you have infections going uphill. Same type of things you'll see. Just be familiar with what cavernous sinus thrombosis is. Show you a couple pictures. Nice swelling, maxillary tooth. Infection goes up. You worry about brain damage, much less death. It's a cute eye. Patient does not look good. So that's what we classify as when they are septic. And this is my 7-year-old goat, Indy. She looks cute there. She's missing one horn now. So she walks to one side. All right. So that is all your good information. Um,